Good morning, good afternoon, everyone. Welcome to this webinar. We will be talking about climate change, migration, and health in Latin America and the Caribbean. I am Baltica Cavieses. I am a social epidemiologist. I lead the Global Intercultural Health Center in Santiago de Chile, University of Development, and I will be hosting this session today. This is a cycle of webinars that started in March this year, and it takes place every 2 months. And today we have the last session. These webinars are co-organized by the uh, Intercultural Center and University of Development, together with the Global Consortium on Climate Health and Education, University of Columbia, Land and Migration, Latin America, and the Inter-American Institute for Global Change Research, and the Chilean Network of Research on Health and Migration, RETICEN. I would like to invite you to introduce yourselves in the chat and to greet us. Please tell us your country, affiliation, and name. We're very happy to have all of you here today. Today, we have simultaneous interpretation from English into Spanish and vice versa. Please find the globe icon at the bottom of the screen on the Zoom. If you click on it, you can select the language of your choice. Please remember to speak slowly so that the simultaneous interpretation can flow efficiently and clearly. Uh, we would like to invite everyone to please share your questions and comments in the Q&A section so that we can select some questions so that at the end of the session, we can talk to the panelists in real time. So now I would like to briefly translate this into English. This series of webinars aims to reflect on the dynamic, complex, and multi-level connection between climate change and international action and the health and people's health in specific regions in Latin America and the Caribbean. This cycle is based on a strong connection between the co-organizers through this webinar series that will lead the exchange of current knowledge based on local scientific evidence and experience, and also real life efforts deployed in the countries and communities of Central America and South America. The first March webinar talked about the climate forces on the health and well-being of children on the move in Latin America and the Caribbean. Webinar 2 in May, we focused on how climate change is changing women's health in Latin America and the Caribbean. Webinar 3, July, we focused on droughts, heat, and extreme weather, climate forces, and food insecurity in our region. Webinar 4 in September, we focused on populations on the move, how climate change affects migrants in Latin American and Caribbean transient camps. And today, the fifth and last webinar focuses on the health of populations in countries affected by climate change, in particular, populations that stay in the countries of origin or when they need to move because of climate change related regions. Climate change is increasingly affecting the health of populations in Latin America and the Caribbean. Nowadays, more people are suffering diseases related to heat waves, extreme heat, droughts, floods, landslides. And these are just a few examples. Changing temperature patterns and precipitation patterns affect the transmission rates of vector-borne diseases. Extreme climate events affect people's mental health and also waterborne diseases because of water contamination. These factors affect food security in rural areas and also the uh, nutrition, mental health, and disease load of these populations, together with droughts and wild forests, fires. This affects people's health, and this affects people who are on the move and other people who cannot move because they cannot migrate in order to adapt to climate change. Still, in the case of populations that remain in countries of origin, many times they become invisible and they are postponed. And this is what we'll be talking about today. First of all, I would like to welcome our speaker today, Dr. Irene Torres. Irene Torres will be making a 20-minute presentation with a PowerPoint presentation. She will be sharing her perspective and experience on this topic. Irene is the strategic advisor to the Inter-American Institute for Global Change Research. She's a member of the steering committee of the working group of the Health Systems Global. She's also a member of the World Immigration Board on Race, Immigration, and Ethnicity, and she's also an affiliate of the UNESCO Health Chair. She's also a member of the of Ecuador's Society for Health board. Irene, it's a pleasure to have you here with us today. You have the floor. Thank you so much again. Please go ahead. Thank you, Baltica. Thank you to our guests. 260 people in attendance, and that's great. This is the end of this series of webinars. Uh, But of course, this is the beginning of the joint work of several organizations in the region that focus on migration and health. And today we are focusing on climate change as well. As Baltica said, today we will be talking about human health in the countries affected by climate change in Latin America and the Caribbean, where these populations, with these people on the move arrive. First of all, I will say something that we all know, but still for some background information. We understand that climate change affects people globally. So of course it affects people in Latin America and the Caribbean. But we want to simplify what happens in the region. And this is why I would like to focus on three types of factors. Some are more or less relevant depending on the region in the continent. And this is interesting because we are addressing the region globally, but actually there are different sub-regions that sustain different types of impacts. First of all, please have a look at this chart. There's so many of them. There's no ideal diagram, because we need to remember that the connection between climate change and health is quite complex. There isn't an ideal way to show this. On this chart, which was published in the policy recommendation document for Ecuador within the Secando initiative, uh, shows in a simplified way what's happening. This was prepared for decision makers. Here we can see the connections between climate change and infectious diseases by referring to the Mora et al. Literature review, which goes back to 2022. I'm here pasting the link in the chat, and I'll also share the abstracts. Yes, thank you. I'll also share the abstracts after this. In the case of climate change patterns, when we talk about the El Niño phenomenon and other progressive changes or gradual changes, they directly impact the proliferation of infectious diseases. So we have an expert here who will be talking to us later on. What happens is that some climate-related events might become more intense, might be more frequent. This can be droughts or heavy rains. But this, sometimes we believe that this means that there will be more infectious diseases, that they will be more prevalent with climate change. But what can happen is that an infectious disease can change from one place to another, as has happened with native dengue cases in Uruguay. This is interesting also. I'll be sharing the link in English and Spanish as well. Because in a way we sort of we anticipated this, and some people told us this is not possible. There cannot be any dengue in Uruguay, but this happened. So here we are focusing on infectious diseases, but you will see that the same climate-related variables, storms, floods, heat waves, fires, droughts, they also take place in different conditions. So we have climate, but also regular mobility within each country. And that's also important because borders are quite permeable. And together with this internal mobility, we need to consider the conditions of each health systems because this will determine how each country will deal with health conditions. More fragile countries or more fragile systems will be more exposed to infectious diseases such as Venezuela. For instance, in malaria, with malaria rates had decreased. In 2020, 70% of malaria cases in the continent occurred in Venezuela and Colombia and Brazil, its neighboring countries. But of course, the number of cases depends on the size of each country and its location, the climate, context, etc. But it's clear that mobility of the population and climate variables have had a strong impact on this. And I think we will have our expert in malaria talk about this later on. Have a look at this picture, the Amazon River, which connects Brazil, Colombia, and Peru. And now they are sustaining a historic drought. Have a look at this, just one boat and one stop along the Amazon River in this case. And they're very important when transporting people and objects. So this is the Amazon River. Have a look at the contaminants discharged into the Amazon in Brazil and the Orinoco in Venezuela. And then now this is driven to the north because of the changing ocean currents that are taking place because of climate change. And these are to blame for increased sargassum rates in the Caribbean, according to the latest research. And this is very interesting because it means that the Amazon ecosystem affects the ecosystem in the Caribbean. I would like to share some research conducted on sargassum as well regarding uh, people seeking care for diseases in Martinica in 2010 because of sargassum. When sargassum decomposes, it can affect people because these gases can cause neurological, cardiovascular, or respiratory diseases. Thank you. Hailey is sharing the slides in English. Thank you so much, Hailey. Have a look at this presentation. It doesn't have many words, but still it helps. Now let us go on to extreme climate events such as heat. And we see this on many headlines nowadays. This is also included in the Lancet Countdown document. Let me just share that with you now. Just a minute. Okay, I'll do that in a minute. Example, the most recent and important example in the last few years is extreme heat. What is interesting about it is that we feel it happen because nowadays it is affecting us in a given way, for instance. But actually, from the womb, actually, the fetus experiences everything the mother feels. And long-term extreme heat during heat waves reduces blood flow to the placenta, it inflames the immunological system, it increases the risk of malnutrition, and this increases the probability of early birth, low birth weight, etc. So extreme heat affects us as fetuses, and then we keep growing. Heat impacts quality sleep among children, and this has been linked to weight problems. Also, for elderly people, there are many studies in Argentina, Mexico showing that there is increased blood flow to eliminate heat from the body. And this might lead to arrhythmias and strokes, etc. This is Ecuador. This map shows the risk of heat in just one country, and we prepared this heat map for Lancet as well for 2014, 2041, 2070. Have a look at the temperatures at which the body can adapt. And we are having a look at minimum mortality rates. This is based on another original article I'll be sharing with you later on as well. These icons represent the temperatures measured in these specific meteorological areas. If we had more meteorological stations, we would have more information about these risks related to heat. Also, one of the authors of the article I've pasted in the chat has also authored this Lancet brief, and she helped us with this map. This is, of course, a long period, 30 years, but you can already see the risks that we will be exposed to gradually, given the increase in surface temperature. Well, let us now go on to another extreme heat event that is also hitting the headlines. This is hurricanes. This is an older hurricane. This is a classic one because we've had changes in hurricanes as well. The Acapulco hurricane came as a surprise even to the WMO, given how it changed its course, its strength unexpectedly, and it was impossible to predict. Why did this happen? Well, one of the reasons was that the temperature of oceans has changed so much that previous predictive models or forecasting models haven't been able to anticipate this change. And this is also an issue. Unpredictability. Early warning systems are very important, especially at the WMO, because it's one of their main agenda objectives. But this changes because authors change as well, or factors change as well. What happened with Hurricane Mitch? Central America and the Caribbean. This is just one example. What a hurricane. It affected water, sanitation, hygiene systems in these countries. This means that, first of all, drinking water scarcity. We interpret when we have a hurricane, there's storms, rain, etc. But hurricanes destroy sanitation and water supply systems. So there's a scarcity of water for cooking, drinking, hygiene. Number two, also heavy rain that might be or related to hurricanes or not, and this leads to floods. And floods are usually related to waterborne diseases, and these diseases are one of the main causes of diarrheic diseases for children under 5, and they are related to chronic malnutrition in children, and they might also lead to the death of children under 5.
I'm now realizing that my presentation is it's a bit tragical, but these are the actual impacts of climate change in our region. Even though I'm not going in deeply into fires and droughts, Baltica mentioned it at the beginning. So fires and droughts have some similar events to severe rainfall and floods, because during a drought, for example, in Bolivia, these were simultaneous fires. These pictures are from simultaneous fires in Quito, in Ecuador, in September, just a few months ago. And in Bolivia, during an extended drought, the water to drink, to cook, for personal hygiene is also scarce. And so this also has a huge impact, which we have seen in other previous seminars, because of the kind of agriculture that is practiced in these areas. We have millions of people depending on this small-scale agriculture. We have people for whom this is their way of life, their livelihoods, the way they support their families. And there's all, if these people cannot live off of agriculture, they cannot feed their families. And this, of course, has an effect on the incidence of child malnutrition. Child chronic malnutrition has the highest numbers in rural areas. And droughts are also linked to the to extensive fires. We saw this because there's a drought, the fires are also spreading really quickly and aggressively. Of course, this directly impacts air quality, which has an effect on respiratory diseases. With fires, sometimes we only think it affects the place where it's happening. For example, here in Quito, it was the city of Quito itself, but the smoke can travel far and reach very areas that are far away. So the fires have an effect in places far away from where the fire itself is happening. And to share the latest study about the Amazon region, about the rate of hospital admissions for respiratory diseases. I don't remember where I have it. Oh, here is the link. And this is really interesting. Is the rate of hospitalization due to respiratory diseases in children under 5 and in the elderly, so it's people over 65. And you can see that in the people younger than 5 and people over 65, it has a higher rate than in the rest of the population. It's around 13% for this population and about 2%. Thank you, Daniel. This is for the Amazon region in Brazil. And we can see how these rates compare. You can see that in the paper with the exposure to particulate matter measuring 2.5 microns, so that can penetrate the respiratory tract, and of course has an influence in hospital admissions for these kinds of diseases. I think I only have 3 minutes left, but I just finished. Thank you so much for the questions you have been posting. I think we have been asked to write questions at the Q&A section so that they can be filtered more easily. Thank you so much. Thank you so much, Eden. Don't worry about the time. It's just a few minutes difference. And it was a really good overview focused on our region, and it's a great contribution. Now we're going to move on to the commentary section. We have William Pan, who's going to speak in English. I'm going to introduce him in English.
Great. Thanks everybody for coming, and thank you for the invitation to join this group. So I know it's hard to listen to someone talk, and I know I'm the first speaker, so I'm lucky. So you're likely to listen more to the first person, so I apologize to the others. So I wanted to give you just a brief, well, I'll start with introducing a little bit more of my work, but I did want to start with the three main takeaways that I hope that you learn from my own experience and from working with others on the relationships between climate, migration, and health. So my own background, like was introduced, I'm a biostatistician. Most biostatisticians do not work in the field. They work in a dry lab. They tend to run clinical trials. My background is a little bit different in the sense that when I did my dissertation research, my advisor was a migration expert and an economic demographer, one of the few remaining, and he really pushed me, which I wanted to do, to collect my own data and to kind of learn what was happening on the ground so that I could understand some of the social factors of why people make decisions, why disease occurs, why people make money and make their livelihoods, and how that influences longer-term sustainable development questions. And I did a lot of that work in Ecuador. And I kind of changed from doing the work in Ecuador. I still do work in Ecuador, but I really focused on understanding the relationships between land use dynamics and malaria. And that slowly converted, and I guess I added to it to look at gold mining and mercury exposure in Peru, and that has expanded to different regions in the Amazon. And now I've also added another study looking at how hunting and wild game consumption influences lead exposure. It's a mishmash of different types of studies, but they do have a purpose and they do have kind of a central theme, which is to really look at how people are making decisions based on environmental change, or how environmental change is occurring because of human decisions, and then what kind of outcomes come out of that. Now, what I will say from some of my experiences, I said I wanted to give you three takeaways right away. The first one I will tell you is that Irene talked a lot about climate extremes. And there's a lot of research in literature, especially when you read, say, the IPCC, or if you read the Lancet Countdown, that generalizes the relationship between temperature, flooding, droughts, other extreme events, with the general statement that diseases will increase. Now, I don't disagree with those statements. Some diseases will increase. But if you take things like malaria, dengue, enteric diseases like rotavirus Shigella or other E. coli's, the reasons why they are increasing are not always the same. It's not a biological change that's occurring to the parasite or pathogen every single time. It's different. The drought that's occurring right now in the Amazon is driving malaria rates up. So the first assumption everybody made was, well, of course, drought's causing malaria. But then you think, well, that's not consistent with what we've said. We've said temperature increases, so that's consistent. We've also said that flooding is more related to malaria. So why are we getting a big increase of vector-borne diseases from a drought? Well, the simple explanation is because the health system cannot reach many of these hard-to-reach communities. The river completely is dried up in some areas. It reduces the transport of supplies. And so there are other social problems occurring that climate is causing that's driving the disease dynamics. And that's something that I think is lost in some of the generalizations about saying climate extremes cause disease, because we automatically think that we have to do something about the extreme. But it's a social mechanism often that's controlling why the disease dynamic is occurring. And I think that's a really important point, especially when we think about migration, because migration is one of the main ways that people kind of adjust their livelihoods to different environmental conditions. The second thing I would say is, and I don't know if this will insult anyone, but migration is a dying science. If you look around the world at the number of migration experts that are actually trained in demography or migration sciences, it's really come down. And it's a really sad thing to see. Entomology is also a dying science, although entomologists are actually increasing in numbers recently because there's a lot more interest in different types of vector-borne diseases. Now, what I would tell you about why that's important in terms of migration being a dying science. So I've published a lot of studies on migration with different epidemiologists and clinical researchers, and their conception and understanding of what migration means is not consistent with what migration experts have traditionally taught on what drivers of migration are, distinguishing between occupational or internal migration versus international migration, and then what those different types of movements are related to a disease or an economic process in the household. The other interesting thing about the reason why migration as a dying science is important is because there is a really bad narrative that migrants are somehow evil, that migration is increasing exponentially. But if you look at the data, for example, Hein de Haas, he's one of the top migration experts in the world. I believe he's in the Netherlands. He has a recent book and a couple of papers showing that the percentage of migrants as a percentage of the total global population has not changed in over 50 to 70 years. It's about 4 or 5% of the global population. So the idea that somehow more people are moving or a greater percentage of people are moving is just not true. So there's a narrative in the political landscape that demonizes migrants, that makes it very hard from a health systems perspective to figure out how do we actually address the health of migrants. And that's something that I think we really need to start figuring out a little bit better. And the last thing I would say about the key takeaway is that I believe that there's a really strong link between climate, migration, and health. We see that in the data. We have a cohort study in the Darien in Panama, where we look at international migrants coming through the Embera communities, and we enroll people who are coming through, and we look for introduction of parasites or pathogens. We look for introduction of new vector species. We look at the incidence of malaria in local populations, and there's a very strong increase in malaria, specifically due to international migration. Now, why it's occurring is a whole other question. But in the Amazon, we have a very similar study. We're looking at international migration along the Ecuador-Peru border in Pastaza and Andoas, and then the same types of migration on the tri-border area of Peru, Brazil, and Colombia. And what we see is that in these migration, I would say in these communities on the border in the Amazon, you have hyper transmission rates, which is completely opposite of what has always been published about the Amazon as having low endemic transmission of malaria. Now, why is that important? Well, the migration in the Amazon is a circular migration of communities, of indigenous communities primarily, that are visiting each other for religious purposes, for trade, for visiting family. And that movement is causing a movement of the parasite, but it's movement through very high transmission zones. And that circular migration maintains an endemic rate. That mechanism of why malaria is being maintained in those areas is very different from why malaria is increasing in Panama. In Panama, you have an increase primarily because the total number of migrants is creating an economic opportunity for a lot of Panamanians. So you have internal migrants from Panama coming to the Darien and exchanging goods. That drives up the rate. And also you just have a lot of migrants that are available to be blood meals for mosquitoes. And so there's this mechanism that is both an internal migration process and an external international migration process in Panama, whereas in the Amazon, we're seeing more of a circular migration effect. And that circular migration is often predicted by what season that we're in, and when people move around. So I'll stop there, and I'm happy to take questions in the Q&A after the session.
And now we will move on to the second commentary from Elaine Flores, a doctor and epidemiologist from Peru, specializing on the impact of environmental disasters on the health of vulnerable populations. And her research is focused on the social determinants of resilience and right to health from a multidisciplinary and gender-based perspective. She is a researcher right now at the Center for Global Mental Health, and she teaches at the Public Health School of the Santa Area University. Dear Elaine, it's a pleasure to have you here today to provide this second commentary on Irene's presentation and also to contribute with your experience in our region. Thank you for being here. You have the floor. Thank you so much. Well, I was listening very carefully to the previous talks, and I would like to thank the organizers of this webinar for the coordination and for having me here, and also Dr. Torres for her presentation on the impacts of climate change and on the populations in our region. As Dr. Torres said, the findings of the 2023 Lancet Countdown Report for Latin America highlight the urgent need of implementing intersectoral public policy that really increase climate resiliency, improve the health of the population. But unfortunately, data shows that these adaptation efforts in the region are still insufficient. We don't have many vulnerability assessments, not many plans, adaptation plans in the region. So we really need to focus on health.
Also, the population in Latin America is now more exposed to changing climate conditions, tending towards heat waves. And this will cause several impacts, among them several consequences on health. Clearly, this evidence and also Irena's presentation are about the need to focus on adaptation and risk reduction. I would like to now talk about psychosocial dimensions and gender considerations in this context. The evidence on the impact of extreme climate events requires a multi-level analysis that includes mental health, especially the mental health of the most vulnerable. For instance, we know that longitudinal states report the significant prevalence of PTSD among survivors. And these rates remain high for years, a long time after the event. And this causes population displacement. And this also means many years of disruption and impact, but it also creates this invisible need regarding unmet long-term mental health needs. Because many times this is not considered in the disaster response protocols. Another major connected impact has to do with droughts, how livelihood agriculture is affected, also food security is affected, water access as well. So these long-term climate events are connected with a significant increase in depression, anxiety disorders. And this is truly wearing in the underserved rural communities. We do have data regarding the connection between long droughts and increased mental health issues. And this has to do with what Irene and William had said, remember, regarding the changing patterns of infectious diseases. We need to also include a gender perspective in our analysis, because we now know that women in Latin America have a different exposure to vectors and risks because of traditional roles socially developed when it comes to managing domestic water and also caretaking duties. And this will be much stronger regarding health services. This also has to do with some pregnancy stages. And as Dr. Torres has said, this is also connected to some critical social determinants. We know that there are strong disparities when it comes to adaptation, for instance, to heat waves. So this intersection of gender and socioeconomic status increases perinatal vulnerability. Therefore, regarding adaptation, we suggest interventions that include 3 items. Number 1, climate monitoring systems that have gender-sensitive indicators and that focus on on the most vulnerable groups, and also comprehensive community mental health protocols when it comes to dealing with disasters, because and for the long term as well, because many of these problems are aggravated in the long term. Also, governance mechanisms that can adapt and acknowledge the traditional knowledge of native peoples that are experts in the area as well. So to conclude, I would like to basically mention 6 recommendations, which is what we have been addressing regarding evidence in the area. But also focusing on what our region is now facing and will be facing as well. So number 1, having integrated epidemiological surveillance systems that include mental health, gender, because this will help us improve our response in the area of health effectively as well. We should also develop standardized adaptation protocols for the region that should consider these different needs, because we know that we need to consider these specific vulnerabilities. And when we do this, the outcomes are much, much better for highly vulnerable populations. Additionally, strengthening regional capacity regarding the psychosocial impacts of climate change that are critical gaps when understanding specific mechanisms. So we know that through different social cultural contexts, climate change is affecting mental health. So we need to better understand this phenomena. We need to train people, inform the public in general, and we need to maybe we need to also focus on most vulnerable population with specific material. And the same goes for decision makers. We need to inform them as well. Um, in the case of health workers, they need to be well trained in order to um, identify these problems at an early stage, especially when it comes to climate change and other factors. So we need to help people identify these issues. We should also promote intersectoral work. We are trying to create some technical panels that focus on health in the context of climate change. Also, maybe I think we should have a more comprehensive response when it comes to developing intersectoral protocols and also information systems that focus on effectively responding to all these and of course acting in a coordinated manner. These are difficult, very difficult times. And the idea is we have misinformation, which is a huge crisis as well. So building climate resilience in a region requires urgent interdisciplinary approaches so that we can address these complex actions together. So thank you for your attention. Please let me know if you have any questions. Thank you so much, dear Elaine. Uh, your opinion is so interesting. Thank you so much. Our third speaker is Maria Alejandra Durner Planella. She's a surgeon, graduated from University of Chile. She has a master's degree in public health and also in humanities and scientific thinking. She's now an epidemiologist in information section of the surveillance and health department at the Institute of Public Health in Chile. She's an epidemiology and public health teacher at the UWV course, and she has also worked in the epidemiology department of the Ministry of Health, at the Department of Health Promotion MinSal, and the Magallanes Health Department. She has researched communicable and non-communicable epidemiology. She has also studied laboratories, environmental contaminants, international health regulations. She has researched TB as well, among other things. Dear Maria Alejandra, I'm so happy to welcome you today. and also through you, the Chilean Public Institute. You have between 8 and 10 minutes for your comment. Thank you so much, Baltica, and greetings, everyone. First of all, I would like to tell you about what the Institute of Public Health has been doing since 2018. We have addressing climate and health. During this time, we have organized several seminars and courses every year. And we have also presented projects with the Ministry of Science. For instance, last year we worked on extreme temperatures and their connection with mortality in different cities in Chile. We have also worked on suggesting a surveillance system and identifying codes and climate-sensitive diseases. The idea is to also develop an early warning system. The ICP is also a member of the panel that addresses the mitigation and adaptation plan for climate change. And this is led by the Ministry of Health in Chile. It's also part of the advisory board that advises the Ministry of the Environment of Climate Change. And regarding our participation in the health forum in Latin America, we had a Congress on climate change last year and we are deciding now if we will be the host of the next Congress. Regarding Irene's presentation, thank you so much. I had the pleasure to meet her last year in the Global Health Congress in Cartagena de Indias, Colombia. Hopefully she remembers me, but well, I remember her. Hi. Regarding what she was saying about the impact of climate change on different countries, I would also like to tell you that given the globalization in the world and our interconnection, every country is affected. There is no country that can remain indifferent to climate change. Therefore, we see many issues: food insecurity, communicable, non-communicable diseases, contamination, fires, uh, diseases, and also how globalization affects every country from an economic perspective. So no country is free of this. I would like to tell you that Chile is greatly affected, especially regarding droughts and water stress, also heat waves. And migration is also an issue, or the change of vector-borne diseases and communicable diseases. There has been a disease distribution change. For instance, at the beginning, we had the dengue vector only in the Easter Island, but now we have found the vector in the central area of the country in Valparaiso. So these distribution changes force us to adapt. Several sectors need to adapt, in particular the health sector, when it comes to adapting the surveillance, control, diagnosis, and prevention departments. That on the one hand, but also the population don't perceive the risk. And this also applies to the malaria vector, because very few people know that the vector also appears in the north. So people do not consider how a population displacement can be a risk. I also wanted to talk about water stress. We've talked about the quality and amount of water, but also quality. Why? We know that water scarcity, droughts can lead to an increase in infectious diseases. Additionally, biological contamination is not the only problem. There's also chemical and physical pollution. And when you have droughts or landslides, we also have the issue of heavy metal water pollution. In Chile, we're exposed to the Andes range with high arsenic levels. And this is a heavy metal that is carcinogenic. And this has led to some issues. For instance, in Antofagasta, we had an issue a few years ago with an increase in cancer rates, and that is now being studied. In Chile, and probably in other countries as well, there are rural drinking water systems. In urban areas, water is more regulated because we have water companies. But rural drinking water is different. These systems include a microbiological surveillance system, but not a physical and chemical surveillance system. Therefore, we need to pay attention to them as well. Another important topic, antimicrobial resistance, or AMR. We know that this is a huge public health hazard, and how these changes in agents increases the use of antimicrobials and the excessive use of antimicrobials. And this requires a multi-sectoral and one health perspective. This is essential to be able to face AMR. Also, regarding communicable and non-communicable diseases, mental health, stress as caused by climate change and how it affects health, I would also like to focus on vulnerable populations. I'm sure you have talked about this as well before. Vulnerable populations, their economic status, how extreme temperatures affect populations with poorer living conditions. Because many times they live in areas in informal settlements. So they are at a higher risk of being affected by landslides or floods. We should also remember their access to health care and why they are more exposed at work. For instance, people that work outdoors, they are more affected by extreme temperatures. Within these vulnerable groups, we should also remember the ends of the life cycle, children and older people, pregnant women as well, which are at a higher risk of health issues in general. Vulnerability might be higher in rural areas as well. For instance, the literature says that there might be specific problems in urban areas because of heat islands. And extreme temperatures are more serious in that case. If we add to this housing without the necessary insulation measures, then these people might suffer even more. Finally, contamination. There is this synergy, including ozone, which is a secondary contaminant given its volatile organic components. Added to sunlight, this has increased mortality for several reasons.
And so finally, to close my commentary, we should remember that having specific alert systems for these diseases is essential, and also to have integrated surveillance. We need to have multi-sector approach under the One Health approach, which is our motto here. Thank you so much, Maria Alejandra, for your contribution to add to the previous commentary. And right now we have our final speaker. We have Daniel Lopez Hermanos, who has a PhD MBA from the Public Health School of the University of Massachusetts Amherst in the US. His research focuses on the intersection between race, ethnicity, migration, and other social constructs, and the link between health and immigration in the US and Latin America. So far, his research has focused on some very well-defined issues, discrimination, distrust in healthcare, the relationship between immigrants and their families, cardiovascular diseases, and use of healthcare facilities, approaches to healthcare inequalities, and strengthening the involvement of civil society in healthcare. He has a PhD in public health from the Oregon University and a master's from the San Francisco University in Quito, Ecuador. Daniel, it's a pleasure to see you again and to have you here to share your perspective and your unique experience on this area. You have the screen. Thank you so much, dear Valtika, for the invitation and your introduction. Thank you to my colleagues for your comments. I would like to share some perspectives on what has already been mentioned. I agree with many of the things that have been mentioned. I am in the US, where we recently had a presidential election where the issue of immigration was really a campaign issue, and I would say clearly anti-immigration from the Republican candidate. And even the Democrat Party also included in its platform some sort of limitation to human mobility. So that's something that is top of mind for me, and many specifically the Republican candidate had a xenophobic and discriminatory discourse, also very separated from what the actual data shows. Dr. Pan was Daniel mentioned the migrant population is only between 4 and 5 of the world population. I can share with you the report from the International Migration Organization that shows that this is a fact. And what I teach to my students here is that despite the fact that that is a relatively small population globally. If we don't have, without having that context, that's an issue. If you see what happened during the campaign, you're like, what world are we living in? It's a huge distortion of the supposed risk or danger. And I mean, we all know, I don't need to say anything else about how immigrants have been denigrated. This isn't the only issue. Where among the work that we have done in the region, with Irene, with Baltica, we see these patterns of discrimination and xenophobia, especially recently with the influx of Venezuelan migrants. So we know this, but yes, I would like to stress again that in the global context, this is a small population, and the discussions around it are disproportionate in relation to the size of the population. And from the perspective of social sciences, that migrant population shows the population, the places that receive them. It kind of gives them a realization about their own living conditions. So access to healthcare is one of these things. And one study we have recently done in Ecuador is that the public healthcare is very limited in the ability to care for the entire population, even though in Ecuador, the constitution in Ecuador grants free access to healthcare. And regardless of whether it's a migrant or not, that right is not being effectively exercised by the population. So they are at a disadvantage. And the Ecuadorian constitution states that regardless of their migration status, people have a right to public health care. But in the context of these public protection systems are underfunded, there are severe limitations. So there are attempts to try and find a scapegoat, a villain that we can blame for all things that are wrong, and these ends up being the migrants, as we have seen in this recent campaign in the US. One of the things that I teach to my students here, kind of to try and counteract that discourse, is that migrants, undocumented migrants, are denigrated, discriminated, but Social Security studies in this country show that those migrants contribute $12 billion to Social Security every year, so that everyone else can benefit. And because of how the public policy is designed, those migrants will not have access to that Social Security resource. And so they're benefiting the rest, all of us. And a big number of that money, a large of that money, it goes to Medicare for healthcare for the elderly. So, and that is not discussed as one of the contributions that undocumented migrants make. And they are rather discriminated. And so in the near future, there might be serious consequences for migrants here in the US, but for the population in general as well. If the undocumented immigrants are deported, who is going to contribute? Who's going to help sustain those social benefits for everyone else around the country? So I wanted to mention, before I forget, I'm going to put on the screen some key data from international migration. And one of the things I have studied is the impact of the money remittances made for example, countries such as Egypt, India are the ones that receive more money from their people who have emigrated to other countries, and this helps the local economy. But also in our region, for example, in Salvador, the largest income for the country, the money sent from people who have emigrated. So we see that part of the impact of those remittances was that it helped people have access to healthcare. And interestingly, to be able to use anti-parasite medications in Ecuador, for example, that different from other countries in the region, you don't need a medical prescription to buy the medication. So what we have found is that even controlling for other factors, that significant connection exists, especially for middle and lower income people in Ecuador. So that's another thing I wanted to mention, and to contrast with what Dr. Pan was saying, as that migration is a dying science, but to provide more some contribution to the debate. In the field of migration studies, there has certainly been a Western bias, more from the local North as receiving society. And so there is an epistemological approach from that perspective, focused on behaviors, that is, from the positivism perspective. But it's not necessarily, I would say, that the field is dying, but if we look at, if we do an internet search, we can find many studies discussing immigration, and more relevant perhaps to what we are focusing on, having to do with climate change and its effect on migration. And before going to the questions, for workers, one of the consequences I see for rural workers is exposure, heat exposure, and the consequences it has for their health. Here, it's something that affects migrant workers. Most rural workers here are migrant workers, and many of them are also undocumented, and they are exposed to this drastic changes in temperature, droughts, etc. I'm putting some links in the chat, and I am here if you have questions or to continue this discussion. Thank you, Daniel, for bringing diversity and other points of view. And thank you for sharing those links in the chat so that we can continue learning. I will go to the final section. We have just 15 minutes left. I may not be able to address all of the questions you have made, but I'll do my best. So I would ask our speakers to give short 1-minute answers so we can cover as many questions as we can. And from Juan Julio Ordóñez, we have for Irene that under the approach from your presentation, we see that we are exposed to significant changes. What do you expect for the future with how weak the results from the COP have been? Well, I understand or assume you are referring to the climate COPs because there are other international agreements that are becoming important. Maybe again, for example, we have the biodiversity COP that has an action plan for health. We have others. So it's not just the climate change COP, but of course, if we don't have agreements at the global level, we don't have a way to go back. And so what our countries need to do is to take adaptation measures. Thank you so much, Irene. Estelina Rodriguez has a question that I will give to Maria Alejandra, Elaine, and Daniel to provide 1-minute answers. And how can we work on the ecology of emerging diseases from academia? Maria Alejandra, please go ahead. Well, as emerging diseases are a significant problem for our countries, first, I would say we need to be prepared for them to happen. We cannot think that our country is not going to get a certain agent just because we have never seen a case or it has never been present. The same thing we said about vectors, but with other health issues as well that may happen. So the first thing is to be prepared, to not think that you are immune, and to always have some resources saved for that. And in academia, not to forget, for example, in our graduate studies, we would go over tropical diseases, but because Chile is not a tropical country, I remember in medical school, we just went over those quickly. And right now we are being forced to diagnose diseases that we didn't used to have. So that's a challenge. Elaine, go ahead. Thank you so much. Yes, definitely. In academia, we have a key role in addressing these kinds of diseases in the context of climate change. And I may be repeating myself, but first we need to strengthen interdisciplinary research, collaboration between epidemiologists, health practitioners, environmental and ecology scientists to have a more comprehensive understanding of these connections, and also improve surveillance, early alert, monitoring systems to integrate environmental and socioeconomic data to have an early response. Also, vulnerability assessment for specific populations and regions, perhaps exploring new tools. We have new technologies that could help our ability to identify and track and also interventions. We should have an assessment of how effective our interventions are in controlling vectors, adaptation to this population to be implemented in public policies. Thank you so much, Elaine. Daniel? Thank you, Baltica. And to add to what Elaine was saying about strengthening our multidisciplinary efforts, multi-institutional efforts, one example of some research we did with Irene during the pandemic is that there was an emergency operations committee from the government with representatives from different ministries of government and also some private sector entities. And by law, there should have been involvement from civil society. But our analysis from the resolutions of that emergency committee clearly showed that there was little or no representation from civil society. And as a consequence of that, those resolutions had a bias towards protecting the interests of the private sector, the industry, and not civil society. So this brings distrust. And so we need to work on that at the times when we don't have emergencies, like we had during COVID, but also for other efforts where, for example, certainly as a contrast to public health care efforts, we have anti-vaccine movements that erode trust. And so we need to work on that now to be prepared and to have those alliances between public entities and civil society organizations now, so that when we do have to work on emerging diseases, we have the strong platform to collaborate.
Thank you, Daniel. Juan Carlos Reyes has a question addressed for William.
Sorry, the question was if there are similar problems in the Caribbean. Is that what it was? Yeah. So the quick answer is no. I think the question is about whether anti-migration policies exist. Not anti-migration, that's probably the wrong word. Policies that reduce the amount of migration. There is not a protocol or a policy that exists. The general research has shown that if you invest in communities that are sending people away, if you invest in those communities, you build resiliency, you can actually reduce the amount of movement out of those communities. That's a universal finding that can reduce migration. It's proven to work, but obviously you need political commitment to invest in those communities, not just nationally for those countries, but you probably need international commitments to help build resiliency to reduce migration.
We have a question for Irene and Maria Alejandra. I'll read it out in English as Juan Emilio has written. Thank you. Well, there's two phenomena that had to do with chronic kidney disease in our region. It increases with age, as is the case globally, but also some studies in Mesoamerica suggest that lack of water, lack of rest, this has to do with chronic kidney disease, especially among rural workers. And these are younger people. Therefore, it's important to admit that climate change is now affecting older people regarding different diseases that might have to do with chronic kidney disease. But it's also true that there are two sides. Some say yes, some no, depending on the evidence. Because we conducted a huge study on this disease in Ecuador. We haven't published the articles on temperature, but it is believed that younger men show a higher incidence. Thank you so much, Maria Alejandra. Anything you would like to add? Well, chronic kidney disease is hugely impacted by dehydration. And we should also remember that in the, as Irene was saying, workers and elderly people, they are very much affected by this. We need to remember that kidney insufficiency remains silent many times, even if it's severe. So we can save lives if we can identify this problem at an early stage. People might feel sleepy or something like that. Sometimes symptoms go unrecognized, especially by older adults. So we need to pay a lot of attention. If there are if there's an alert for higher temperatures, then health staff need to know about this. But sometimes these older people do not even seek care. So it's the family members that need to be aware of dehydration symptoms, especially among older people and children as well. Please remember children in this case. Thank you so much. Thank you both for your answer. Now, I would like to ask a question addressed to Juan Emilio. Vector disease determinants and other diseases that have to do with hydrometeorological events are even riskier, and experts cannot influence policies to help people prepare for all this. We know what to do, but cannot really do it. What should the academia do in order to strengthen our influence on health and public policy making? Thank you. I only have 1 minute. Thank you for the question. It's similar to what I said before. We need the academia to know people outside the academia, because what we can see now in this era of misinformation or disinformation is that it's not enough to publish a scientific article for people to, and we cannot expect people to read it. We need to ensure that we participate in fora like this one, so that we can actually talk to the society, so that we let people know that there's a real risk and of these information based opinions do not reach public policies. We need to expand the work we do. And this is even more visible in Latin America than in the global north. We need to actively participate. And also, of course, we do have our limitations. So we need to work with civil society organizations, networks, local, regional, national governments. All of this is important. It's no guarantee, but at least we can better chances of these informed decisions, informed opinions being considered in decision-making efforts.
Mind if I
Thank
add
you
on
so
to that
much.
answer? Thank you. So we have an early warning system for malaria that is operational in Honduras, Panama, Peru, Brazil, and Ecuador. And I would agree with everything that Daniel says. However, I would add that civil society and policymakers have to equally reach out to scientists to make sure that things are effective. We have had different success in influencing the way ministries of health are responding to outbreaks, so we can predict malaria 12 weeks in advance and 9 months in advance with extreme high accuracy. Honduras and Panama has already begun using our monthly updates to change the way that they are responding to malaria. Ecuador, Peru, and Brazil are more resistant. And I think it has to do with, at the national level, there's a little bit more bureaucracy that they have to deal with in order to change the way policies are made. At the regional level, obviously, they can respond, but they need resources. So there is, I think there is a role that civil society needs to play in making that collaboration work.
Thank you, William. Okay, so we are out of time. This is all for today. Thank you so much for being here today, in particular to the almost 320 attendants we had today. Dear Haley, can you please turn on your cameras so that we can see you? Congratulations to every panelist, to the attendants for the questions. Thank you so much. And well, this is the end of this climate change, health and migration seminars in Latin America and the Caribbean. It has been an honor to organize and co-organize the event. Thank you so much. See you next time.